Thank you. All right, hi everyone. I'm Lindsay Sizemore. I'm the Viral Hepatitis Program Director for the Tennessee Department of Health, and I'm going to be your facilitator for this session today. So today's agenda will include introductions and announcements, a didactic presentation on Hep C treatment in correctional settings by our guest speaker, Dr. Carla Thornton, an adult case presentation with time for Q&A, and then of course, closing remarks. So first, some in-chat introductions, as well as some brief announcements. So before we get started, I'd like everyone to take a second to introduce themselves in the chat. Please include your name, your role, your organization, and if this is your first ECHO session with us. And I know we have some newbies today, so very excited. So while everyone is introducing themselves in the chat, I also need everyone to take 2 minutes to ensure you're registered for this event. You can utilize the QR code pictured here on the left side of the slide or the website listed on the slide. As a reminder, registration is required for our accrediting body, the Southeast AIDS Education and Training Center, and for continuing education. So I'll leave it here for just a second so we can get caught up. Jeremy Chase, is this your first ECHO? Jeremy, I know you're here. Okay, it is Jeremy's first ECHO, so we're going to welcome Jeremy. Jeremy works with our Department of Corrections, so very exciting to have him here. Okay, next slide. So please turn on your video and mute yourself unless speaking, and please come off mute to ask any questions that you may have. Anastasia, has anyone joined by phone only?
Can you hear me?
Yes.
Yes, there's 2 phone numbers in our list.
Okay. Can you tell me what numbers those end in?
Yes, just one moment. The first one I see ends in 332.
Okay. If your phone number ends in 332, would you like to come off mute and introduce yourself so we know that you're here?
Yeah, this is Dennis York, FibroScan nurse for north side of Tennessee, northeast side.
Awesome. Thank you.
Thank you.
And the other number, Anastasia?
The other number ends in 938.
All right. If your number ends in 938, would you like to come off mute and introduce yourself, please? I'm echo pausing. Okay, we'll go on to the next slide. So please never discuss PHI, and please always treat everyone with respect. And so with that, I'm going to turn it over to our guest speaker today, Dr. Carla Thornton, for our didactic presentation. Dr. Thornton, just say next slide, and we'll be sure to advance the slides for you.
Thank you so much. Good afternoon, everybody. I'm Carla Thornton, infectious diseases physician and one of the associate directors at Project ECHO. And I'm going to talk to you a little bit about my experience working with our correctional system in New Mexico. Next slide. I have no conflicts of interest. Next slide. So I just want to start out by, I'm not going to talk a lot about the general data about Hep C in prisons because it is just terrible. Basically, there's not any national level data. The estimated prevalence rates we have them for some state correctional systems, but not most of them. And they vary tremendously. People have different testing approaches. So it's just really, really poor data. Probably the biggest study that's been not the biggest study, but the paper that sort of reports on the most the prevalence that we know about, it ranges from about 12 to 34% in that paper, which is 20 times greater than the general population. So we have a huge hepatitis C problem in our correctional systems, state correctional systems. And the CDC estimates that correctional populations bear about 40% of the hepatitis C disease burden in the United States. So again, really, really important population to think about when you're thinking about hepatitis C, and particularly about hepatitis C and national elimination. Next slide. And treatment data, treatment rates are even harder to find. This is sort of an interesting set of basically all I could really find in this clearinghouse about treatment rates. So as you can see, they're very, very low in the single digits for the ones that are reported. And so the data is just really not very reliable. Next slide. We have a really big hepatitis C problem in New Mexico in our state correctional systems. We have the highest of those that are testing regularly and reporting. We have the highest seroprevalence rate, which was published at 41.1%. It's actually a little bit higher than that, and I'll talk about that, our experience in testing. Next slide. And we also have a huge problem statewide in New Mexico with hepatitis C. We have one of the highest death rates due to hepatitis C in the nation. Next slide. So we have a long-standing relationship with our Department of Corrections. When ECHO started back in 2003, 2004, one of our initial partners was the Department of Corrections, and they were involved in a study that we did with AHRQ, where what we published in 2011 about hepatitis C and how it was treated as efficiently and effectively by primary care providers and prison providers as it was by specialists. So they've been a part of ECHO for a very long time. We have 11 state prisons in New Mexico scattered all over. And for those of you who know New Mexico, it's a huge state. So these are just in the middle of nowhere, most of them, except for the ones sort of central around here near Albuquerque. Our average daily population that's a little bit high. This is when we first started, it was about 7,000. It's probably more like about 5,500 at this point. And we started testing everybody upon entry in 2009, and 50%, I would say 48 to 52%. That's been the range since we started testing. When I first got involved with them, they weren't doing testing for virus in people unless they were being worked up for treatment. But for the last 5 years, they've been doing reflexive testing and we have about a 35 to 40% viremic rate. Oh, next slide. Sorry, I was trying to change the slide myself. That didn't work. Okay, I know this is a very wordy slide, but I'm just going to tell you a little bit about the story. So 2004, as I mentioned, we got involved with them. That was the interferon era. So we were treating just a handful of patients with them, people that were the sickest, but also were not too sick that they couldn't tolerate interferon. So basically we treated very few patients until about 2015 when the DAAs came out, and we were treating them, but we were guiding the providers in the treat. We had these ECHO sessions with the providers in the prison system, and we were sort of guiding the therapy and helping them. And we treated about 50 to 100 people per year. And I'll tell you a little bit more about the New Mexico Peer Education Project, because it was a really important part of, I think, hepatitis C treatment in our prisons and why we really started it. And in 2020, our legislature appropriated a lot of money for hepatitis C treatment in the corrections department. The prisons also partnered with our Department of Health to procure 340B pricing, which made it more reasonable for us to treat more people. And we've been collaborating with the Department of Corrections for a long time, and whoever their medical vendor is at the time. And right now it's Wexford Health Services. And so we worked very closely with them to revise the hepatitis C treatment guidelines and really ramp up treatment. Next slide. Next slide. So again, we completely revised the treatment guidelines. Next slide. And this is what our process looks like, and this has been going on since 2020. So as I mentioned, we have universal hep C antibody testing with reflex to RNA at intake. It's opt-out, but I have to say that there's very few people who opt out of testing. For anybody who has viremia, we do baseline labs and transient elastography. When we first started this, everyone was getting a fiber scan, but after about a year, we looked at our data, and there were fiber scans, and didn't really make a lot of sense in the younger patients. So now everybody who's 40 and older gets a fiber scan, but people that are younger than that do not, unless we feel like we want to go back and do one after we look at their labs. My team basically reviews the labs of all HCV infected incoming people weekly. So the log comes to us. We look at all of their labs to sort of see if we think that there's something concerning and somebody we would need to need to be presented to us. And monthly, we also have something called a master log. So the Department of Corrections shares, we have basically a master log of all infected people in the corrections department that we review monthly to sort of pick up on people who've had new labs and possibly have cirrhosis or somebody that we're concerned about. They also, as part of their baseline labs, they get HIV testing, they get Hep B triple serology testing as well. So people without evidence of cirrhosis or some other complicating factor are treated by using the simplified algorithm, which is basically the same thing as what the AASLD has produced. So it's straightforward. Basically, they get treated without any labs on treatment and just get post-treatment SVR labs. And they're just treated directly by the providers for Wexford Health Services. The sicker, more complicated patients are presented to us on a weekly echo session like we're doing right now, and we help to guide their treatment. Next slide. And this is just for reference, but this is basically taken directly from the AASLD guidelines. So these are the people who have any of these issues would be presented to us so that we could help them treat these patients. Next slide. So this is what our numbers of treatment have looked like. Like I said, before 2015, basically we were treating just a handful of people. And we treated between 50 and 100 up until about 2020. And in 2021, as you can see, that went up dramatically. And when I say we treated, I mean that they treated, but we're helping sort of to guide the whole program. In 2023, we're almost up to where we were at all of 2022. So we're thinking that probably by the end of 2023, that there'll be close to 1,000 people who've been treated this year. Next slide. And this is just a little bit of information, some data on the people that we've treated so far. They're mostly men, just because that is what our prison population looks like. We have a very small female prison population, but they're getting treated sort of at about the same rate as the men. The vast majority of them are between 30 and 50 years of age. About 8% were cirrhotic. And then the other thing that I don't know, about your own prison system in Tennessee, but we have about a third of our Hep C patients in the prison have genotype 3. And genotype 3, as you know, is associated with injection drug use. So that's a lot. There's a lot of drug use in the prison and outside the prison. So a lot of people who inject drugs are in prison. Next slide. And this is just another way of looking at this treatment ramp up. And I just wanted to point out, but just so in the blue, prior to this treatment ramp up, we were hearing about every patient who was treated for hepatitis C in our prison system. After the ramp up, as you can see, we heard about a lot of patients. It's getting fewer and fewer because we've basically now we've treated most of the people who have cirrhosis. So over time, that's what we would expect to see, that most of the people are not presented to us. Most of them are treated on the simplified algorithm with no labs on treatment. Next slide. And so I just wanted to switch gears a little bit and talk about the peer education program because I think it's an important part of our treatment program. In 2009, when we were involved in treating hepatitis C or working with the corrections department treating hepatitis C, I would hear about a patient who had acute hepatitis C almost every week. And I thought they would have, 1,000, their ALT would be 1,000. And I was like, why, we're just treating a few people and so many are getting infected in the prison system. So we decided to try to do something to try to educate people in the prison about hepatitis C transmission. And so we started this project that was really modeled after a program in Texas called Wall Talk that was done for HIV education in the prison system in Texas. Next slide. And so what we do is we go into the prisons and we do a 40-hour training for about 12 to 15 people at a time, where a lot of the training is about how to educate and how to be teachers. We also we train them on content, mostly infectious diseases content, but also on addiction and other things that are really prevalent in the prison system. And then we leave and they do these 10-hour workshops with their peers and train them a lot about hepatitis C, but other things as well. We do a lot of follow-up with them, and we also do a biweekly echo session with the peer educators from all of the prisons. And they present cases, not cases about patients or anything like that, but present cases of things that are going on in the prison and their workshops or other things that they say they want input from their peers about. Next slide. These are just some pictures of some of the peer education. This is one of the trainings that we did, and they do all of their own posters and everything. Is they don't really have any, they have to use their own art for their classes. And for all of the infectious diseases, we have what are called the 5 questions that are listed here. So they should be able to teach on this for really any infectious disease that we train them on. And then they talk to their peers a lot about Hep C testing and treatment. And they also, Hep C reinfection is an issue, and it's certainly an issue in our program. So they can also educate people about how not to get reinfected. Next slide. This is just one of our the last groups that we educated. Next slide. And then, like I said, we do these echo sessions twice monthly with the peer educators. And we always have somebody from the Department of Health on, which is great because during COVID, we were able to really give them updated information about COVID and things like that. Next slide. And I truly believe peer education is critical. I don't really know what the program would be like without peer education, but I think it's really, really important because when something happens during our program, we notice that something's going on that we're concerned about, then we can train the peer educators to really train their peers on again, how to not get reinfected. We had a period where there were a lot of refusals for treatment, and we sort of investigated what the reasons for refusal were, and then we can have the peer educators talk to them about that as well. So they can educate them about treatment, about reinfection. Again, if someone's refusing, they can talk to them about that. And they can also encourage people to explore alternatives to tattooing and drug use, which are very, very prevalent in our state prison system. Next slide. So lastly, we do hepatitis C testing 90 days prior to release as well, because some people get infected while they're in there. Some people get reinfected after treatment. And we give them this, we don't, but the prison staff give them this piece of paper right here that basically has what their status is on it and whether or not they need to seek treatment when they get out. And there's numbers at the bottom, as you can see, for people to call if they're still in need of Hep C treatment when they're released from prison. Next slide. So we've had some challenges for sure. As I mentioned, there was a time when there were a lot of refusals. That's kind of not happening as much anymore. A lot of people get released before their post-treatment SVR labs are due. So we don't, and a lot of them also, not a lot, but some people do refuse their SVR labs. So we're missing a lot of SVR labs. We've had multiple reinfections. I don't really have the data on it that I can tell you about, but there have definitely been reinfections. We work with the Department of Corrections Health Services Administrator, but we also work with the medical vendor. So it's a sort of complicated group of people to work with. And then linkage to care upon release is hard. I mean, we're doing what we can, but it's a lot of people just don't get treated when they don't get linked directly upon release. Next slide. So in summary, like I said, the data on prevalence and treatment in state prisons is really, really lacking. We feel like the program that we're doing combines several things that are really important. Universal opt-out screening is really, really, really important upon intake into the prison system. We have low barrier treatment with DAAs. Basically, anybody who wants treatment can just go to medical and say, that they can basically say that they want to get treated, and then it will happen. And there's no, before we started this program, you had to have like a clean record. You couldn't have had any infractions. You couldn't admit to any drug use because you would not get treated. So that none of that stuff happens anymore. With the complicated cases get presented to us, so they don't have to send people out for expert consultation. And then, as I mentioned, I really truly believe that the peer education, I mean, it's hard to measure what the impact is of the peer education, but I feel like it's a really critical component of the program. And we cannot do Hep C elimination nationally without having a coordinated and treatment and prevention approaches inside of our prisons. Next slide. I think that's it. I'm happy to answer any questions or anything anybody would like to talk about.
Thank you so much. That was a really great presentation. I have a question that I would like to ask. So what happens, this is something we've been dealing with, I don't want to say a lot, but it has come up and I don't think we have a really great workaround. So if someone starts on treatment and then they're released, because, this is obviously more common in the jails than in the prisons when we don't know when people are going to be released, how do you ensure they get their medication to continue once they're released?
Yeah, it's really, really hard. And so we try not to let that happen. I mean, we actually are trying not to start people right. If we know they're going to be released in the next month or so, they don't get started, because we've had some people who got started and they left before they were supposed to, as you know, and it's been really, really hard because they walk out the door and then they try to, they can walk into some of them just don't have any idea how to do it because they weren't really told. But even if they walk into some clinic and somebody has no experience getting hepatitis C medications, it's really, really hard. So I think it's ideally, if people are going to get treated in the prison system, ideally they would get treated and complete their therapy before they leave. But like I said, we've had some people we've tried. I mean, they've come to our clinic and we've had to call Medicaid and basically see if we could get them, immediate treatment, get their medications approved immediately and all that stuff. But it's just a mess when people get out and they're not done with their therapy. One of our prisons, or not one of our prisons, but most of them, if somebody were to leave, they would give them enough to complete that month, but they wouldn't give them the next month. So yeah, it makes it really, really hard.
For sure. I see a comment in the chat from Kimber. Amazing. I would love to see a similar program in Tennessee prisons and jails. So Kimber, exciting news that the Tennessee Department of Correction has been doing their peer education program since January of this year.
Oh, awesome.
Yeah, it's something, as you know, Dr. Thornton, we tried to get off the ground like several years ago, and then the pandemic and all of that. And so my understanding is they started back up in January, and we're now going to be deploying a team. Well, there's 2 nurses that will be trained to do it. They'll alternate, but they will be going with them every month to a new site, I think starting this month. So
wow, that's very exciting.
Yeah. Definitely in prisons, Jeremy. I don't believe we have that in jails, but I'm definitely not the subject matter expert on that, so we very well could, but I have not heard about it if we do. Any other questions for Dr. Thornton?
I don't have a question. This is Lindsay. Dr. Thornton, I just wanted to make a comment that I really like the paper that you give them upon release that tells them their status. I know working in regions when you have inmates that are released and then they report back to their, region where they reside. Sometimes they don't understand their status completely, or they are not exactly sure what testing they've had completed. And it becomes really difficult for us to get records once they have been released. And so that paper is so informative.
I'm happy to share that with you guys if you want to. I mean, you can use it for sure. I mean, we just made it up, but you're happy to use it as well.
No, I think it's a great informative paper.
Yeah, it's been really helpful because, I do Hep C clinic in our community clinic here, and people will walk in with that paper which is helpful. I mean, we still have to document this stuff, and now we have a health information exchange in New Mexico, which has been a game changer, honestly. So we can get all the labs that are done in the prison system are sort of available to us through this thing called Synchronous. So that has been really helpful too. But just to have them, yeah, because it motivates them too, and they know like what is it that they need to do.
I also wonder too if it would be beneficial to maybe add, if they do have a history of treatment, to add like that information on there, because so many clients don't, they know they went through treatment, but they have no idea of the name or even the number of weeks they went through. And, you know, that can play a factor if you have to go through retreatment.
Right. Yeah, that's a really good point. Yeah, thank you for that.
Any other questions for Dr. Thornton?
I have a question for you guys. So what is happening in terms of Hep C treatment in the Tennessee prisons?
Does someone from TDOC want to speak to that?
Well, of course I will, since that's
Thank you,
me,
Jeremy.
waiting for me to get off mute. Okay, I was typing this to Lindsay Zimmerman. You know, we've had a couple phone calls regarding our discharges and the paperwork that needs to go with them. And I am happy to tell you that we have created a discharge packet that when a patient is discharging, it signals for them to have another sheet filled out instead of just the discharge form. And that sheet lists everything that the patient needs, not just for hepatitis, but for any, let's say, long-term care type disease processes. Their vaccine cards, you know, it includes a lot of information, most recent labs, treatment dates, regimens that they've been on for, you know, HIV, HCV, HBV, things that when they walk into their doctor's office, they can hand that to their doctor and they won't be starting from scratch. And so that comes from discussions that we've had with Ms. Zimmerman and Ms. Sizemore and a few other. Oh, let me introduce, I am Jeremy Chase. I am the TDOC HCV treatment coordinator. That's for the Tennessee Department of Corrections. So basically what I do is I review every patient who we know is HCV positive and then prioritize them, sort them, and track them for treatment and for follow-up. As you were discussing earlier, we do basically the same thing you do in New Mexico. We follow the simplified algorithm for most of our cases. We do have what we call the TAC committee, the Tennessee Advisory Committee on Hepatitis and HIV, although I am not part of HIV, but our ID consultant does handle both our hepatitis C and our HIV cases. So they are tied together when needed. He's informed of both. Basically, we have our budget, and our budget dictates how many we can treat on a monthly basis. And so we set our goal, and then we prioritize based on fibrosis stages. We have, just like looking at your treatment numbers, it felt like you had just come and stolen mine, basically, because same thing. As you know, in the beginning, we were lucky if we could treat 10 a year, and then we went to about 50 a year, and now there was one point that the state did give us a lot of money, and we were treating 500 a month. Then when we ran through that, of course, they cut our budgets back, and we do average 50 to 60 a month now. We keep a centralized, what we call HepCore, the Hepatitis C online registry. All patients, once we know that they are RNA positive, they go into our registry, and then that's where we keep their labs, and we track their labs, and we track their treatment status, and then of course their follow-up status, and we keep them in there until they SVR. And once they SVR, depending on their fibrosis stage, they can come out of the registry, but they may stay in cirrhosis chronic care clinic where we track their, their fibrosis and do ultrasounds on them every so often, to rule out things like hepatitis, liver cancer. We're lucky enough to be in the 340B program for the TDOC sites, but we have in Tennessee, we have a small number of private prisons that do not qualify for 340B. So what we do is the private prisons and the TDOC statewide pharmacists, they work really closely with both Gilead and AbbVie and are constantly getting them to give us better pricing. So, one of them will say, well, we can come down to this. And then the other one will go, well, we can come down to that. So even though we are not in the 340B range on their sides, we do have very good pricing for both the CoreCivic sites and the TDOC sites. And basically, we treat as many as we can on a monthly basis. And I say that we cannot eradicate hepatitis C for 15 years because that's when I plan on retiring. But our goal is to eradicate hepatitis C from the Tennessee Department of Corrections. It's a very, very lofty goal. And considering there's months that we get more RNA positive people into the system than we are putting out of the system, that I don't know if it will ever be achievable, but thanks to programs like Project Echo, which our director Boyd actually came and trained in New Mexico, and our Sarah, why can I not remember Sarah's last name, but she is our Project Echo person who goes out and trains the sites, and she tries to get another site every month up and running with a goal of having I say 14 sites, but we may only have 13 because I count one that's it's one site, but it's divided into two. Our goal is to have the peer education program up and running at every site by the first of the new year. And I do believe that we're going to have that. And I have seen by our numbers that it is definitely beneficial to our population. We are able to see that patients that have went through the program are way more likely to adhere to treatment, to decrease their risk. And I definitely feel that the inmates themselves listen better to the instructors who are, inmates than they do to staff. I mean, they look at us, they're like, yeah, we're listening to you, but as soon as you leave, we're whatever. But the instructor passes them on the yard and says, hey, make sure you make it to class, make sure you do this, make sure you do that. And they're like, oh, yes, sir. Yes, sir. So I do believe that if you work in a system that does not have a peer education system, it would definitely benefit your system to get with Project Echo, get with the New Mexico people, and try to get something up and running in your system. If you can't do the Project Echo itself, just any type of peer education program, it's been very helpful for us, and I am very grateful to the Project Echo people. And that's it. Unless somebody has questions, I'm going to shut up because Lindsay knows I could talk forever. See her smiling? Sometimes when we have meetings, she has to kick me under the table so that somebody else can get a word in. So it was very nice meeting everybody by Zoom. I really, Dr. Thornton, it was an excellent presentation. And like I said, I'm like, man, they're stealing my stuff. So basically, I'm going to turn around and steal your stuff because I have to present some things to my superiors tomorrow. And I screenshotted some of the stuff for that you were presenting so I can tweak it and turn it into TDOC if you don't mind.
Totally fine with me. Thanks, Jeremy. Nice to hear all the amazing work you guys are doing.
Well, we are just, I hate to say that we had to be sued to understand the importance of this, but once the lawsuit, TDOC did have a lawsuit against them. We did win the lawsuit, but it was all because of the lawsuit showed us that we needed to make a better effort. And that is actually how my position got created. There was not a position before that, but I was able to convince them, and a few others were able to convince them that this was a serious issue that really needed to be focused on, and it couldn't be spread out among 2 or 3 different people. One person needed to be able to bring it together. And now I wish that I'd have just kept my mouth shut. But no, it is a very rewarding position. I actually feel like we are making progress. I can actually see that we're making progress when we started with 5,000 plus people and we're now down to 2,000 some odd people just in the past 3 to 4 years. I mean, we were able to keep treating during COVID because we were able to focus on it with HepCore and having one person as a central place for the sites to come to. We were able to get it focused on and keep treating people, while other DOCs and other entities just pretty much during COVID locked down and gave up on everything. We kept on chugging. And I will hush after this one, I promise. But I just want to say thank you to Lindsay Zimmerman, Lindsay Sizemore, and all of our TDOH people. We've tried to meet. Before COVID, we were meeting on a monthly basis. Since COVID, we try to meet on a bi-monthly basis to discuss anything that they can help us with and we can help them with. We provide them information. They provide me data and statistics. And the one thing that I really, really like is we both check labs. So if I miss a patient that might be reinfected, I get an email from them going, hey, do you think have you seen this? This patient's been reinfected. Or I'll get an email from them saying, hey, can you check on this person? We don't have labs. They've not had labs in so long. So the fact that they track labs and I track labs really is beneficial to the TDOC program. And it really helps me because when I'm trying to keep up with 2,000 to 3,000 patients, I'm going to be honest, every now and then one might just slip through. And so it's nice to know that I have that backup to catch when the labs are showing that, hey, this person needs to be followed up on. And even if I've already caught them, it's nice that they'll be like, hey, just want to make sure. I really appreciate that. And I really appreciate the relationship that we have. So thank you, ma'am. I have said my bit and I will turn it back over to, I guess, Miss Sizemore.
Thank you, Jeremy. I did not pay him to say all of those nice things. He did that all on his own. But thank you for being here. And Dr. Thornton, thank you for being here and for that presentation and for helping us get our echo off the ground too. We're very appreciative. Okay, we've got about